So we have a confirmation with a second opinion that he definitely has prostate cancer.
Hello, I'm Reggie Hicks, producer of the documentary and outreach project, If You Are My Brothers, and also host of the If You Are My Brothers podcast. And we're all about prostate cancer conversation. I want to welcome everyone watching on YouTube, LinkedIn, Facebook, and to those listening on your favorite podcast platforms. Now, in today's episode titled The Science of Prostate Cancer, Breakthroughs on the Horizon, we'll explore how emerging technologies and new approaches are giving renewed hope to patients and families, featuring one of the leaders in the field, Dr. Robert Gatenby. I'll be calling him Bob throughout the show, so he told us that was good. So don't think, he's not, you give him all his props. We are happy to have Bob here. So whether you're a patient, caregiver, or simply curious about where cancer care is headed, this conversation is definitely for you. Now, before we dive in, a quick reminder, we always do this on every show. This podcast is not a substitute for your medical team. The opinions and medical issues we discuss are not a replacement for treatment. Always consult your healthcare provider. So we got that out the way and our lawyers are happy. No, just kidding. Now, we call this series Prostate Cancer Conversations, and we invite you to join us in the chat with your questions, comments. Don't be shy. This is real life. And remember to like, share, and subscribe as we go through this journey together. And always, to learn more about this podcast and the If You Are My Brothers documentary and community engagement project, please visit us at ifyouaremybrothers.org. That's ifyouaremybrothers.org. Now, I'm honored to be joined by Dr. Robert Gatenby, or Bob. And Bob is the department chair and program leader of diagnostic imaging and interventional radiology cancer. And I'm trying to get this right, also co-director of the Center for Excellence for Evolutionary Therapy. His pioneering work in imaging and evolutionary therapy is helping reshape prostate cancer care. And so we are so honored to have him on the show. I've seen a number of interviews and webinars and other podcasts he's been on, so I know he's very busy. So joining us all the way from Tampa, Florida, we want to welcome Dr. Gatenby to the show. Hello, Bob. How you doing?
Hi, Reggie. Yeah, thanks for having me.
Bob, I wanted to start, again, I'm a layperson. I've seen some of your presentations and I'm just blown away, not just by the complexity of some of the things that you've been working on, but also the way you've been able to disseminate it to the rest of us and to understand the work that you're doing. So let's get an overview kind of where we are. Can you paint a picture of the current state of prostate cancer care, where we're succeeding and where are we falling short?
I think it's probably fair to say that metastatic prostate cancer, now, if it's prostate cancer that's localized to the prostate, that's always curable. Metastatic disease of the prostate, although there's many therapies and many new therapies, it remains fatal. And this is despite the fact that there have been multiple new drugs and new strategies offered in the last 10 years. The mortality from prostate cancer continues to increase, and it's starting to approach maybe 40,000 men a year.
Wow. So we still have that as an issue. As we look at that, are there still myths and understandings that you continue to encounter even today about prostate cancer diagnosis and treatment, just in general?
Well, I think in general, the medical community is dedicated to this idea of using maximum tolerated dose, give as high a dose of drug as you can, with the intent of killing as many cancer cells as possible. That's always the kind of background intent of therapy. And if you could cure the disease with a therapy, that would be totally appropriate. And yet we know that prostate cancer remains a fatal disease. And that is because even though they're very good therapies, they are not curative in themselves. And the prostate cancers have, like most cancers, have an incredible capacity to evolve resistance. So I would argue that for men with prostate cancer, The proximate cause of death is not absence of therapy, it's evolution. It's evolution to resistance to previously outstanding therapy, very, very effective. To me, we need to understand evolution. We need to, since evolution is increasingly the cause of death, we need to actively include evolutionary kind of theory in treatment.
You pioneered this idea of adaptive therapy, as you mentioned, treating cancer like an evolving ecosystem instead of trying to wipe it all out at once. What's the significant advantage to this approach compared to traditional methods? I think I remember you talking about the example of the goats on the Galápagos Islands.
If you want to cure a cancer, then there's techniques that in evolution to do that. These are called Anthropocene extinctions, meaning that our species is killing off other species. And trying to cure cancer is the same thing. The human beings need to eradicate the population. But that's hard to do. And for hundreds of years, or for at least 100 years, cancer therapy has focused on this idea of a magic bullet, the idea that you could give a drug that would kill all the cancer cells and none of the normal cells, a magic bullet. But they haven't come up. Magic bullets are not here. What we've learned from Anthropocene extinctions is that you don't need a magic bullet. It's not like the dinosaurs where the asteroid came in and killed them all. In Anthropocene extinctions, typically they're caused by a sequence of perturbations. None of them by itself can cause extinction. It's that combination. So the Galápagos goat is a perfect example of that. The Galápagos goat was these goats were left by pirates and sailors on the Galápagos Islands so that they would have food when they came back and visited. And they became feral, and they spread throughout the Galápagos. And eventually there's about 500,000 of them, and they began to crowd out the native species and damage the flora and fauna of the Galápagos. And so it was decided to kill them off. And the first thing that they did was they got military people with automatic weapons. They put them on helicopters, and they gunned down the herds, and it was a slaughter. The population declined very rapidly, but then it stopped declining. And the reason is that the goats evolved a resistance. In this case, what happened was that they learned to hear the helicopters, and they would run into the woods and hide. So now they can't, they couldn't reach them. So what they then did eventually, after multiple different things, is they used what's called the Judas goat. This is a female goat that's been neutered. They have a radio collar on her, and they spray lots of hormones. The Judas goat will eventually join these small groups of surviving goats, and then they track them down and kill them. So they eradicated the goats, but it's not like you do it all at once. It's a sequence of events. Your first therapy results in a loss of the population, but then it pushes the evolution. They evolve a resistance. If you can understand that, then you can target those basically strictly based on the evolution. So the goats evolved resistance by going into the woods, keeping on the same therapy. It was just flying around military people with machine guns wasn't going to get you anywhere. On the other hand, the Judas goat would never have been effective in these large populations. The Judas goat is really designed to identify these small hiding populations. And so when we talk about curing cancer, I think that the evolutionary approach in that setting is not like a single magic bullet. It's the idea of sequence the therapies in a way that works. That's hard to do. That's kind of a theoretical mechanism at the moment. It's not really something that we're doing actively, although we do have extinction trials going on right now in breast cancer and prostate cancer.
Yeah, this is talk about there were some other scenarios talking about first strike, second strike, attacking cancer like a boxer, right? Kind of going at it, weakening it, and then coming back and then doing the therapy over time, actually letting the cancer grow a bit as it kind of evolves and then attacking that and then over a period of time. And I saw your some of your numbers on that. Now, you said that that's something that you're not doing that now. Is that what I'm hearing? Is that in any practice or not? Or have we shifted?
We've shifted a little bit. What I sort of proposed as we go through with this is first identify your goal. If your goal is cure, then you've got to use a certain set of strategies. If you don't think you can achieve a cure, and that's just not practically possible, then what we should be doing is not treating as if you're trying to cure the patient, but rather treat it in a way that controls the cancer for as long a period of time as possible while maintaining a high quality of life. Knowing whether we can kill a metastatic prostate cancer is still something, and how we can do that is, I think, would say it's unknown. So for the most part, what we're doing in metastatic prostate cancer, this adaptive therapy, which is designed to control the cancer for as long as possible by preventing or at least delaying evolution of resistance to conventional therapy.
Right, because, you hear often that when you get into metastatic cancer and it's starting to spread, that the treatment itself almost becomes worse than having the cancer, kind of just beating yourself up. And the body's weakening, right, over time with this kind of bullet approach, if you will. You mentioned that your work is around metastatic prostate cancer. When we talk about aggressive cancer versus slow growing cancer, which that was what I had in my case when I was diagnosed, how do we determine? I mean, what are some of the things that are happening now to say, okay, your cancer is kind of heading down that road. It's more aggressive than slow growing. Is there a way to determine whether prostate cancer is going to be slow or aggressive?
Prostate cancer is a Jekyll Hyde disease. Most men, the disease is retained in the prostate. And so it is not spread beyond the prostate. And that's when you treat for cure. You absolutely can't do anything otherwise. On the other hand, when it's metastasized, when it's spread to the bone or the lymph nodes, at that point, that's metastatic disease, and that's not generally curable. Now, there may be strategies to cure metastatic disease, but that's in its infancy. That's not going to help anybody who has metastatic prostate cancer now. What we want to do then is to use evolutionary principles to take the drugs that already exist in prostate cancer and use them better. That the goal in this case shifts. If you think about the kind of standard way it's treated now, is that the whole focus is on the cancer cells that are sensitive to your drug. You kill as many of them as you can. But the problem is that you're selecting for the resistant population and you're eliminating all of their potential competitors. So they can then proliferate unopposed. What we want to do is to focus on the resistant populations that ultimately determine the outcome. And what we want to do is to use the cells we can control, which means the cells that are sensitive to our drug, to control the cells that by definition we can't control. So now the prostate cancer cells that are sensitive to your drug, you don't want to kill them. I mean, you want to kill some of them. You want to make sure that you don't have symptoms. But as long as that population exists, you can manipulate it to delay or even prevent proliferation of the resistant population. So as long as you're sort of playing this game, and that's the idea, is we abandon the idea of trying to cure, and we don't treat as though we're trying to cure. Using this maximum tolerated dose therapy, when you know you can't cure the person, I mean, historically, you just know that's not a possible outcome, it doesn't make sense then to smash them with the highest amount of therapy you can give. What you want to do is the minimum amount of therapy that you can use to keep the tumor under control. And so the sort of fundamental error, I think, in oncology is this intense idea that this has been the dogma for 50 years, that you want to treat with maximum tolerated dose. You want to kill as many of the cancer cells as you can. The problem is that you're promoting the cells that you can't control, and they're the ones that ultimately determine the outcome. So we shift focus to controlling those resistant populations. The advantage of this is because we don't need to use maximum tolerated dose drugs, that we can achieve a long-term control using way less drug than you would ordinarily use. So, for example, in our trial in castrate-sensitive prostate cancer, what we do is we put the therapy on, we wait for the PSA, which is the serum marker, to drop to maybe 50% of its pretreatment value, and then we stop. We stop therapy and we just let it come back. But as it comes back, you're not putting any pressure on resistance because you're not treating. And in general, the sensitive cells have a fitness advantage over the resistant cells in the absence of treatment, because they don't have to carry whatever this molecular machinery is that allows them to be resistant. And so if you just leave them alone, the tumor cells will grow back, but the sensitive population will grow and they will suppress the growth of the resistant population. So you just come back and then you recapitulate this initial population. And again, you just give a little bit of drug. You just treat it, just keep making it go down, let it come back up. And what we find is that in this trial, the men are allowed to have normal testosterone levels more than half the time on the trial. And so you greatly reduce the toxicity associated with androgen deprivation therapy, and yet you still get a more prolonged treatment response. So you're saving costs and you're saving toxicity side effects and still getting a better outcome. So, longer control. So that's kind of the very quick summary of the ways we do this.
And as you look at it, you're measuring the patient's lifespan, I guess, from this treatment. And is there a difference between what you're talking about with the adaptive therapy versus other therapies of just sort of going after it? Do your patients tend to live longer, or what's sort of the outcome that you've experienced?
Sure. In our two trials, in our first trial, which we used abiraterone, which is Zytiga, which at the time was second-line therapy. So after the men progressed through androgen deprivation therapy, this is Zytiga or abiraterone was the next treatment. What we found was that there's two ways that you can measure this. One is if people get Zytiga and they get standard of care, just maximum tolerated dose continuously until the tumor progresses, how long does it take before they progress? And the answer was about 14 months. What we found is that we could exceed that to about 30 months. So a significant increase. And then you can measure outcome based on how long after they start this therapy does the patient die. That's the overall survival. And here, we increase the overall survival by about 2.5 years while using less than half of the drug. Abiraterone is a very expensive drug. And so that represented a significant cost savings. In fact, it was calculated and published as saving about $70,000 per patient per year. So it was very significant. Our second trial is looking at what is standard first-line therapy, which is now androgen deprivation therapy plus abiraterone. And again, that's typically given with both drugs together continuously. And the best trial that's been published had a median time to progression of 46 months. Guys in our trial are doing so well that we haven't reached the median. Several more of them have to progress for that to happen. We know that the median time to progression cannot be less than 73 months, more than 6 years.
Before we started, you had mentioned going down to Tampa, and I got to ask you about this question. And you said one of the things that when you went down there, you wanted to bring on mathematicians. Tell me, how does mathematicians and prostate cancer therapies, how does that work? And again, I'm a layperson, so no formulas. But I really, that was intriguing because I've seen you do presentations that have formulas, and I was like, this is really math. So how does that work? How does that happen?
It goes to what's fundamentally true about cancer. What is a fundamental description of cancer? And I think you could call it a complex adaptive system, a complex dynamic system. There's a couple ways that you can say, but the point is that it's a system because there are many components to it. In other words, many cancer cells. They interact with each other in complicated ways, and they're always sort of evolving, so that there's a constant change. The most well-known complex dynamic system is the weather. Again, you get the idea. Lots of things, lots of dynamics going on, complex. And what we've learned is that to understand the weather, we need to use mathematical models and computer simulation. A great story is about Benjamin Franklin, who wanted to see a lunar eclipse. Now, in those days, it was always assumed by science that the wind carries the storm. And he wanted to see the eclipse and couldn't see it because a nor'easter blew through Philadelphia. That's a destructive storm that typically comes from the northeast. And he assumed, because the winds were coming from north, that his brother did not also see the lunar eclipse in Boston. And it turns out that the lunar eclipse occurred before the storm arrived in Boston. So the storm was in fact moving south to north, not north to south. It was moving against the wind. And so he was actually the first scientist to recognize that the wind does not carry the storm. But this is a very good way to think about how our intuitive sense can fail to understand the dynamics of a complex system. It makes intuitive sense that the wind would carry the storm. I mean, everybody looked at it and that's what everybody thought. But in fact, it's far more complicated than that. And in fact, the wind does not carry the storm. The wind is a part of the storm, not the cause. And so that difference in using intuitive thinking, which is how cancer is typically treated and how these protocols are designed, again, the idea that you kill as many cancer cells as possible, it's intuitively appealing. The problem is that in a complex dynamic system governed by evolution, that approach is usually about as bad as you can do. So the idea then was to bring mathematicians into the cancer center so we could start to really look at the cancer as a complex dynamic system. And you probably know the butterfly analogy, that a butterfly flapping its wings in Brazil could cause a tornado in Texas. And that's often used as an example of how you just cannot master a complex dynamic system. But what we've learned is that tendency to magnify small perturbations is in fact something we can use to either maintain the cancer, control it, or to kill it. And so everything that's being done here with evolution-based therapy has that basic model in mind, is that we have to rely on the mathematical models to show us these non-linearities, and so we can understand them and master them, rather than having them beat us every time.
That makes sense. So with all of this going on, where are we now in the future? How is this being used? And if I'm a patient, how can I look at this as an option? Is it available, or kind of where are we now in the application process?
I would say that we are at the first step. There's a lot of opposition in the traditional oncology world, and so there's not a lot of places that know how to do this, much less offer it to patients. But there's some oncologists, and there are some oncologists that are willing to do it, but want some education on how you actually do this, why you do it. And, my group sort of tries to be an educational asset to anybody that, wants to discuss this. There's a large clinical trial going on in Europe right now looking at the same thing. And I'm not involved in that trial, but I made sure that I contacted the investigators so I could give them some of the pitfalls, some of the mistakes that we made in the design of our initial protocol, so they don't have to reinvent the wheel and have problems with it.
So in order to kind of look at this, because I know there are probably men and watching this and will say, well, that makes sense to go at it. I love the whole Judas goat analogy or the boxer. Makes sense. And so would they contact you, or are there you said there weren't many other centers that were kind of taking this adaptive strategy. And I'm just trying to get to the practicality of this, because to be honest with you, and we talked before, I had my prostate removed about 12 years ago. And then this year I had a recurrence as my PSA started to go up, not having a prostate, obviously. And so it went up as high as, I think, 0.46. And I was diagnosed with a recurrence, possibly in the prostate bed. So I'm going through proton therapy, it's like every day, right? For 37 treatments, not on the weekends. And there's no indication of that's where it is. I mean, I did the PSMA scan and that nothing has really shown up. So for me, it's like, why did, 12 years out and this happens again? I thought they removed the prostate. It was gone. There was no indication it was outside of the prostate. But I do know that we're talking about molecules here. And so my treatment right now, right, is kind of like bombarding it, going after it. I mean, and now I'm kind of like, well, will it come back, or what do I need to do to kind of advocate for maybe a therapy that will kind of address the longevity and not just treat it like you said, right? I mean, just going at it full blast. Should I be concerned, or?
What I would say is that if you can treat for cure, then treat for cure. No one should be dissuaded in doing that. But once the tumor is metastatic, then treatment for cure is not traditionally possible. And in that setting, I think what you want to do is maximize your lifespan while minimizing the toxicity of the drug, of whatever is your treatment. So that's what I would say. I would never, never, never tell anybody who's undergoing therapy for cure to not do that. It's only when you get into this incurable state of metastatic disease that's where we want to sort of have a place and at least try things that are, I think, evolutionarily sensible, because the cancer will evolve to anything. And you have to remember that the cancer has the whole human genome to find strategies. It has access to everything. It uses proteins that are ordinarily found only in fetuses. The prostate can deploy, believe it, this is astonishing to me, the prostate can deploy some proteins that are ordinarily only found in the brain. And in fact, cancer cells do that frequently. They can pull from things to adapt. And I think that's what gives them their enormous power, is that they have so much information available to them. We tend to underestimate what they can do.
Yeah, as a matter of fact, I saw on one presentation where I think you listed like 3 types of prostate cancer cells or cancer cells, and how one, they could live off each other, adapt that way. I mean, you kind of get rid of one, but it's actually adapting and living off of the ones that you're trying to get rid of. Am I understanding that right? I'm just, that's kind of what came to mind when I saw that.
Yes, our models typically, it depends on whether you're a splitter or a lumper here. You could argue that there's multiple subtypes of prostate cancer, different mutations and different things like that. When you build a math model, I think Einstein said this, that you want to build something as simple as possible, but no simpler. So what we did at the beginning is to say, well, everything we're doing here is about treating patients with hormonal manipulation. So let's define the subpopulations based on their response to testosterone. A lot of people say, well, that really is missing a lot of subpopulations. But again, the idea is as simple as possible. And so what we found is that works. That model is sufficiently complex to capture all of the dynamics that we're seeing, at least at the moment. As always, with the way you do models is that you use the prior data to kind of establish this. You make predictions, you test the predictions. And as things happen that are not consistent with your predictions, then you have to study that, and then you have to understand it. One of the things that I think we don't do in cancer therapy is that we don't conduct clinical trials very well. So they do these clinical trials that can cost $1 billion, and they have agent A versus agent B. At the end of it, they can say agent A is better than B with this level of statistical certainty. But what they don't ask or answer is why. Why is A better than B? And could we have given B in some way that would have been better than A? Or could we have done better just in general? And so the idea here is to not view the failure of your treatment personally. We have made a mistake. We should have done better than this. And so the way we do this is that we take data from the clinical trial. We then update our models, and then we apply the model to every patient. And the model tells us what happened. Why did we see what we saw? And then more importantly, the model says, you could have done it better. Here's how you could have gotten a better outcome. And so, again, this is the after action analysis that the military uses all the time. They study what they did so they can do it better. And so I think that's kind of one of the pillars. So one of the pillars of the strategy is at the beginning, define what you want. If you want to control the cancer, then don't give therapy as though you wanted to cure it. You've got to have, your therapy has to match your goal. And similarly, do these after action analysis and analyze what you did. Assume that you should have done better. We tend to, I think, take this, the idea of tumor progression after treatment, as just, well, it just happens. But I think we should change that. We should change that and say, that should not have happened. We should have controlled this longer. What could we do better? And we have failed here. And rather than just taking it fatalistically, like, well, that just happens, we need to understand that and then do it better, so that we're learning not just the sort of adaptive therapy regimen is better than standard of care regimen in this particular group, why was it better and how could we have done it better? And we have learned from that. From each of these trials, we've adopted new strategies. We've changed the strategy a bit based on what we've learned so that we can do better. And so our second trial, the time to progression and I'm sure overall survival is going to be way better than it was for our first trial because we learned from it. And so each trial is more the same.
So looking at that, what gives you the most hope right now about where prostate cancer care is headed in the next 5 to 10 years? It's like we talked about predicting the weather, right? It's a little difficult to do that far out, but where do you see us in this 5 to 10 years?
I think, and I'm going to be provocative here. There's two things that have happened that we've learned. One is that we now have learned that we can keep patients alive with first-line therapy for many years. I have other patients that I mentioned have been stably cycling for 14 years and are still doing fine. One of the things that we've learned from analysis is that there is a potential strategy to, once the men go to castrate-resistant prostate cancer, the therapies are limited and the lifespan is short, probably 2 years-ish. What we've learned is that at least in some men, when they progress from castrate-sensitive to castrate-resistance, we may be able to push them back. And this is something called directed evolution. So for centuries, humans have used directed evolution to breed desired traits in animals, in domesticated animals. So what we've tried to do, and so far we've been successful in one patient, and we have a clinical trial that's going to open on this, is to push them back from castrate-resistant back to castrate-sensitive and essentially start everybody at the beginning. And so we have cycles within cycles. Again, I'll be provocative and I'll be optimistic. I think we can eliminate prostate cancer as a cause of death within 5 years, which is not to say cure it. What I think is that we can convert it to a chronic disease with an excellent quality of life so that people just sort of live with it like you do with diabetes and heart disease and everything else. We just manage it. I think we're pretty close to getting there.
Yeah, it's almost like even HIV, where people now have the regimen, they're living with it over long periods of time. Everybody can remember Magic Johnson when he was first diagnosed, and that was 20 plus years ago, and he's still with us. That's very encouraging. As we close out, I wanted to ask you, our viewers and listeners, if they had to remember just one thing from this conversation, what would it be?
Think about evolution. Evolution is the fundamental principle of all life, and cancer is just life. It has to obey those rules. It's not magic. It's not some kind of evil entity. It's simply an evolving population. It's very good at evolving, but we understand evolution. And our understanding of evolution, I think, can trump the ability of the cancer cells to evolve resistance to the point that we can maintain control for prolonged, if not indefinite periods of time.
Wonderful. I like the idea of looking at this, particularly metastatic prostate cancer, as a chronic condition and not a death sentence. So I really do appreciate, Bob, Dr. Gatenby, for what you and your team are doing. Is there a way to contact you, or and we'll put it in the show notes as well, but what's the best way to get in touch with you?
The best contact is through the email. It drives my wife crazy, but I answer emails, but I don't generally look at texts. And I religiously respond to these, but it's important that the patient understand that they have to have an oncologist who is captain of the ship. And so my role in this is one of education. Here's the likely principles. Here's what we have seen in our clinical trials. Ultimately, it's the patient and the oncologist that have to move this forward. If they want to see an oncologist in Moffitt, then that's fine too. But that's a long trip for most patients, and so it would be much better if we could deal with their home oncologist if that oncologist is willing to speak to me about it. So that's my basic thing, is that it's fine to contact me, but you have to know that I'm going to insist that you bring your oncologist on board with this, because that's the person that has to make the decisions with you.
Right. Right. Well, thank you so much. We'll make sure we have your email address in the show notes as we go forward. Again, we appreciate your time. Someone said, we always try to get this finished by the time folks can get to Thursday night football.
Okay.
So we really do appreciate you, Dr. Gatenby. We continue this great work, and we will definitely be in touch.
Thank you. It was very nice to meet you. Nice speaking with you.
Well, again, we want to thank Dr. Gatenby, or as he's known now around the If You Are My Brothers podcast as Bob. He's reminded us that prostate cancer and its cure is evolving and being more precise in how evolutionary therapy, adaptive therapy changes how we think about controlling cancer. I also want to make the point, for me, the big takeaway is Bob talked about metastatic prostate cancer and the work that they're doing to try to go from being a death sentence to chronic kind of condition, which I think should be applauded. But it also brings to the point of knowing where you are, knowing your PSA, staying on top of this so that hopefully you can catch it early. As he said, he would not tell someone to, if you're talking about curing, and this is what happens when prostate cancer is found early and remains in the prostate, that there's a higher rate of it being cured. And so that's important because that means you, me, anybody else listening to this, brother, uncle, granddad, know your numbers, know where you are, insist on getting a PSA so that if by chance do come up and you have prostate cancer, that you can move forward without fear, knowing that these breakthroughs are going to help you and beat this thing in the long run. So that's the takeaway from this evening. You can find more resources and episodes at ifyouaremybrothers.org, our website. We sort of try to put everything together there for you. If you're listening on our podcast, the website will be in the show notes. And if this conversation has been meaningful to you, please share it with someone who might need it. We've had so many folk to say, my significant other, my partner, I've turned them on to the conversations that you all are having, and it's kind of resonated with them to go and at least be proactive. We're trying to do this, what we call health action. There's so much out there about health awareness. That's a part of it. But again, once you're aware, you need to act. So we're hoping that as we proceed through Prostate Cancer Month and beyond, that you will share this with a loved one, you'll subscribe, and we can build this community of men as we look to eradicate this thing, folks. We just need to get it done, and we can do that together. Now, you can connect with us and listen to past episodes, again, at ifyouaremybrothers.org. You can also follow us on social media. All episodes are archived on our YouTube channel as well, both video and audio. So if you're not familiar with this whole podcast thing and subscribing, I know I'm a boomer, so I get it. You can go to our website and listen to all the different episodes. And we've got so many more episodes coming up. We want to also let you know that this episode is sponsored by the Creator's Nature Blend, pure and natural herbs and serums, oils, and tonics, handcrafted with homegrown and wild-crafted ingredients. Melissa, a good friend of mine, she and her husband are building this wonderful, wonderful company to help people naturally deal with some of these issues that we all have, from diabetes and even hair growth. So check them out at thecreatorsnaturalblend.com. That's thecreatorsnaturalblend.com. Special thanks to our producer, Danny Garcia Pozo. Appreciate him. And also to Zach Reynolds at Borkhouse Productions for our opening theme. If You Are My Brothers is a project of Straight Street Media, and you can learn more about Straight Street Media at straightstreetmedia.org. Until next time, if you are my brothers, you will share this message. And we'll see you next week, next Thursday at 7. Take care. Be safe. Peace.